Well, hello everybody, and I'm right by the river in central London. I am not Charlotte Toulouse. Charlotte is a wonderful, wonderful person here at Guy's and St Thomas's, but she has just lent me her laptop because it's connected to the Guy's and St Thomas's Wi-Fi signal, whereas my usual means of accessing this product is not. My name is John Wilkes, and I have the privilege of being the Chief Executive of the Institute of Health and Social Care Management. And as many of you on the call now will know, we are formally partnered with Guy's and St Thomas's, who represent our regional hub for London. And it's in that frame, really, that today we are absolutely thrilled to be putting on our first showcase event with our London regional hub, Guy's and St Thomas's. I'm sitting here in the magnificent River Room, adjacent to the Houses of Parliament, just across the river there. It's a wonderful setting. There's lots of people in scrubs and other patients and so on, just gathered round on the grassy knoll outside, just enjoying the early autumn sunshine. But that's not really why we're here today. You don't need a guided tour of London and the river. What you really want to hear about is virtual wards, and today we are delighted to be joined by Dr Shaheen Khan. Shaheen is consultant in palliative care and is also the clinical director for integrated local services at Guy's and St Thomas's, and I believe somewhere maybe in the background as well we have Edward Middleton, and Edward is policy and portfolio director for Guy's and St Thomas's, but it's Shaheen really who's going to be leading this initially by giving us a short presentation about what they've been doing at Guy's and St Thomas's around virtual wards and how they've been using that in the local community to really enhance the patient experience and, of course, provide some efficiencies around service delivery. So Shaheen, if I may, I'm going to hand on to you in just a moment. If I could just ask you in the audience, if you wouldn't mind, just let's hold on to questions until Shaheen has just finished his presentation. It's going to be about 15 minutes, something like that, and then we can move on to the questions. And then we're going to be moving after that into a further showcase, which is around transformation in research delivery at Guy's and St Thomas's, and the one and only, the wonderful Claire Harris, head of research workforce at Guy's, is going to be helping with the delivery of that one. But Shaheen, let's hand on to you first of all. So we're really looking forward to this. Edward, I think you may be a non-speaking in the background part of this initial bit, but feel free to come in when Shaheen has completed his initial presentation. Over to you, Shaheen. Thank you.
Thank you, John. And yeah, very happy to guide us through the first session, and very much looking forward to hearing Claire's session afterwards. And I think there might be some exciting links between the two for us to draw out as well. As John mentioned, I'm a palliative care doctor by trade, and also providing some clinical leadership for the virtual ward work, not just at Guy's and St Thomas's, but we are very much leading that on behalf of our partners across Lambeth and Southwark, working across primary, secondary, social and voluntary care. So it's a really exciting partnership journey, as well as, of course, delivering exciting benefits for our local residents in Lambeth and Southwark. I'm here very much to represent lots of fantastic work by lots of different people, some of whom are on the call, which is great, some of whom who can't be here. And also we're here to share, but also very much to learn. I can see that we've got some key leads registered to attend, so I'm hoping that we've got some virtual ward experts from across the country, and I think the Q&A section will potentially be quite rich, and also hopefully some follow-up conversations afterwards. I think the virtual ward work also is an exemplar of the importance of working across organisational boundaries. I've mentioned some of those boundaries locally, and also across what can be sometimes inadvertent professional boundaries. So this is really a success story so far of joint strong work, not just by clinical colleagues, but also the strong leadership from our operational and management teams. And I think this is really the key to the success of the work so far, and will be the platform for anything that we seek to achieve moving forward. I've got some slides which obviously I'll run through, and then really happy to create as much space as possible for sort of Q&A and discussion at the end, if that's okay. So I'll just move through. What I plan to just run through is some definitions, which is important in this space. Brief summary of our journey so far. We've got some very established models, but also there's much we can learn from others who are perhaps newer to the space and possibly a bit more agile as a result. Talking about our current models of care, and then very importantly, our next steps. I'll start by just pausing on the definition of virtual ward. This is a term that is now increasingly common since, probably the last year or two. It's in NHSE parlance. We're all being asked to respond to the NHSE requirements around this, but sometimes it can be interpreted very differently, not just by different organisations and staff, but also by our patients. So a virtual ward from the NHSE perspective, which is the definition, of course, that we work with, is something that is a safe and efficient and effective alternative to NHS bedded care. So what we're talking about is the provision of care that would otherwise historically have required an inpatient admission. It's not lots of other things, so expanding community services more generally, chronic long-term condition management, intermediate care, daycare, all of those things, of course, are absolutely essential. But when we're talking about virtual wards, we're talking about specific clinical models and interventions that prevent hospital admissions and or reduce length of stay, so extracting people from inpatient beds. Now, whilst of course we're responding to the challenge NHSE have laid out for us, it's important to remember that this in itself is a good thing. If you think about all the pressures and the environment we're working in, whether that's the financial constraints, population health, the increasing multimorbidity of the population, the aging population, and very importantly, what our patients want, all of those things point towards the same thing, which is essentially delivering the right care to the right patients in the right place at the right time by the right people. And for many people, that's an inpatient hospital bed. But we know for many, many people, that's not the right place for them to be. And sometimes because of our historical and organisational constraints, the path of least resistance for a patient or a clinician involved in their care might be to send someone into hospital or keep them in hospital for that extra day, just so we're absolutely sure that they're sorted. But actually, we need to change the model and actually shift all of that into the community, provided we can resource it properly and we've got the right governance and checks and balances, of course. So the benefits, I think I've touched on many of them. I think they're hopefully self-evident to the people on this call. And it's important to also reference the benefits for the providers of healthcare. So, of course, if we can deliver the right care in the right place, it means that we're using our very limited collective resources in the smartest possible way, where appropriate, reducing pressure on the emergency department, reducing pressure on primary care, social care, voluntary sector, but making the best of perhaps underutilized parts of those systems as well. It's also really important to emphasize the benefits for staff. So we have staff in a variety of different teams at Guy's and St Thomas's working in the community day in, day out. I spend most of my clinical time in people's homes. And I think this offers us a really unique opportunity to really upskill and develop a specific part of the workforce and develop this cadre of experts who are expert not just in the clinical work they do and the care they provide, but also in the setting in which it's delivered, because community has its own foibles like any part of the system. And unfortunately, at this point in time, the undergraduate and postgraduate curricula for our clinicians and also for our managers doesn't necessarily equip people fully for the community aspects of the system in which we work. So this, I think, provides a basis to pick up some of that work nationally. In terms of the local context, we're catering in this situation for a population of around 625,000, and like all parts of the country, we've got our own unique considerations as well. So if you look at Lambeth and Southwark, it's an incredibly diverse and rich environment, but we do suffer with relatively high levels of socioeconomic deprivation, and there are significant inequalities in access to care. We've got an aging population, which is by no means unique, and a population that's set to increase as well. In terms of our local response, we've had services that you might consider falling under the virtual ward umbrella for a number of years. So our at-home service, or hospital at-home service as it's been known, is approaching its 10-year anniversary. So through that service, our teams have been delivering what was previously regarded as hospital level care in people's bedrooms. So we're really excited looking ahead to the 10-year anniversary. But that's not all that we do in terms of virtual wards, and we have a number of other services, not just at Guy's and St Thomas's and King's, but also in the wider sector, that deliver care that falls under the virtual ward definition. So if the great work of our integrated respiratory teams, our palliative and end-of-life care teams, and work such as our outpatient antimicrobial therapy teams. We're also exploring opportunities to link in with our paediatric colleagues at the Evelina with their Evelina at home model, and lots of other opportunities, whether that's oncology, surgical pathways, sickle cell crises. You can take your pick. If there's a clinical scenario that could benefit, we're interested in talking about it, and we'll be keen to hear from colleagues what's happening in your areas. So much more detail available in the slides. I should have said at the start, the slides will be shared after the meeting with the attendees. So the team, like I say, set up in 2014 with a small but tightly formed group of staff with high levels of anxiety and corresponding governance on top of it, because this was a national first, really. And then since then, the team's massively expanded, not just in size, but also in the different professional groups involved. And elements of the team are also now completely integrated across health and social care, both in Lambeth and in Southwark, which is really exciting. So this team is really delivering integration with a lowercase I, as well as achieving the wider agenda that we all talk about. The service has evolved hugely across those interfaces. And more recently, of course, the virtual ward discussions offer us an opportunity to take that to the next level. I'll talk briefly later about some of the key developments that we're currently involved with and what we hope to do moving forward. And just some detail that, again, will be shared with you in terms of the size and capacity of this part of the team. I think one of the key messages with all virtual ward work is that it needs to be responsive. So it's not just about having the capacity to deal with all this clinical need. It's about how quickly we can get to these people. So for our urgent community response services, our target nationally, as everyone will know, is 2 hours. So if someone's in their own home and perhaps they're being seen by a GP or a district nurse and they need to step up in their care, or if someone's being discharged rapidly from hospital, our teams can get to that person within 2 hours of receiving the referral. And that's incredibly quick if you think about the geography and the complexity involved. And also if you think about corresponding now, albeit historical targets like in A&E, where you have 4 hours to sort the patient out, by getting to that patient within 2 hours, we can really start to change the system for the better. So we've got a number of strengths, of course. We've had almost 10 years to build this service and learning from colleagues, not just nationally, but across the world. But we've got lots of areas that we want to develop further. I've touched on some of them, and I'll focus in on one or two in a bit more detail. If we think about the gauntlet that NHSE have rightly laid down to us, we know that across the country, the aim is that for every 100,000 population, we want to have 40 to 50 virtual ward beds. And how you define a bed is obviously complex in this setting, but there are ways to do that. At the moment, locally, if we look at Lambeth and Southwark, we need to, if we think about where we started maybe a few months ago, we need to effectively double what we're providing. We also need to make sure that those beds or that capacity is utilised, of course, because there's no point of having people ready to help if the referrals aren't coming through or if we can't respond in the right way at the right time. So there are some utilisation targets around 80% occupancy and so on. And everyone across the country is responding to this. And within the SEL ICS, we have a community of practice so that not just within Lambeth and Southwark, we can learn from other parts of the system as well. So there are some challenges to this as well. So it's not all a bed of roses, of course. And you know, there are some very obvious challenges that we all face, whether that's finance or the broader concerns around the workforce. And we know that even if we had this nirvana of having unlimited funds, we would still struggle to recruit to post because of the national challenges, whether you're looking at nursing, allied health professionals, pharmacy, medicine, support workers, and of course operational leaders. You know, these staff don't grow on trees. So whilst we can expand staffing to a greater or lesser extent, there has to be another way to do this as well, and we're augmenting our model, particularly around technology. So at the moment, if you think about the capacity of the system as a whole in Lambeth and Southwark, as of today, we've got roughly 170 virtual ward beds out there. So at the moment, that reflects what's out there in the community, and it's made up of those different teams that I've referenced. Where we need to get to on our trajectory is to get up to around 200 very quickly this winter, and then moving through December into next year, looking at an even more significant step change. And we're not alone in this, and different parts of the country have started from a different base. We started from a relatively mature position because we've got this 9 to 10 year history, but others have joined this particular party relatively recently. And as I said, that's not necessarily a bad thing, because it has led to agility and the ability to test different models and learn collectively. Much more recently, over the last couple of months, we're really excited about a partnership we've entered into with a company called Doctor, who are an established provider of lots of different things, including the ability to provide technology to support virtual ward care. And Doctor have done this to a greater or lesser extent with many different teams in many different parts of the country. And for us, it's really exciting to explore how we can use that to dock into an established, mature service, which we're not necessarily starting with a completely blank page. And what this practically means is, for the first time for us, we're now able to access technology that can transform how we deliver care. So whereas even just going back a month or two, if one of our patients needed their blood pressure checked or needed an ECG, needed their oxygen saturations checked, that would generally involve us sending out a very senior and trained clinician out to do that task. Now what we can do is, as soon as that person enters the caseload, we can send them a bespoke personalized set of equipment, including wearable devices, tablets, phones, and everything else, so that when those observations are needed, the patient and their family can do those. They're automatically uploaded centrally, and Doctor are providing a remote monitoring service with inbuilt escalation to our clinical teams, who can then respond accordingly. And what that means is two things, really. One is we can make the best use of our limited clinical staff and spread them out over a greater clinical need, but also it gives us greater confidence in taking people onto the caseload who otherwise might not have had access to things like overnight monitoring and assessments and qualitative and quantitative data coming in between the visits. So this potentially is a game changer, and other parts of the country are further ahead in this than us, and we're keen to learn. We've had to create new governance models. So I touched on the fantastic partnership working, but that's not been without challenges. So if we talk about Lambeth and Southwark, together collectively, but actually each of those place-based partnerships has their own governance structure. So we had to essentially work with our colleagues to create a new governance model which satisfied the requirements, but also was nimble enough for us to make rapid changes. And I think we've done that reasonably successfully so far. These are some key themes we're talking about, so these won't be a surprise to you. So making sure we're avoiding inadvertent risks of creating bottlenecks in other parts of the system, managing the risk of digital exclusion, particularly with some of the technology I referenced, and also being mindful of the clinical risk. And of course, we've got robust governance structures around this. But for the individual staff involved, we need to also empower them to be confident, knowing that their patients are being well looked after, even if they don't necessarily have their eyes on them 24 hours a day. We've got some metrics attached to all of this, and also we've developed with our colleagues in City, which is one of our local innovation and transformation teams working across SEL, a maturity matrix, which essentially provides us with an ability to score ourselves and how far along this virtual ward journey are we, because virtual wards mean different things to different people, and people are approaching it in different ways. So we've developed this tool, which we've shared and we're happy to share further, so that teams and locally can assess how far they are based on where they need to get to. So for ourselves, if you want to be really specific, we're at 68%, which technically is called maturing. So you probably don't need a table to tell you that, but it's really helpful when you consider all the different aspects and where we are along that journey. I think I've talked about a summary of our next steps, and some key things for us to do are to develop better methods to accurately predict the local population needs. So it's all very well providing capacity based on nationally driven ratios, which obviously are themselves based on data and needs analysis. But for us locally, what is the actual capacity we need? Does that vary, for example, in winter compared to summer? What does it look like at 2 o'clock in the morning versus 2 o'clock in the afternoon? What does it look like during a potential surge in COVID cases? Do we need to do some things differently in flu season? And what can we use from our local population health data in terms of our long-term conditions work, the work on the Vital 5 to prevent morbidity? How can we start to tie these things together so that we're looking at an end-to-end system-wide solution? We're obviously working with all of the relevant specialty teams to a greater or lesser extent. So we're really well developed when it comes to our links with palliative care, heart failure, respiratory services. I think we've got massive opportunity with oncology, surgical pathways. And again, that's where we can learn from outside the organisation and bring that back in, because people are doing that really well in other parts of the country. That's the end of the slides. Email address there if anyone's got further questions, but I'll stop sharing and hand back to John and colleagues. Thank you.
Thank you, Shaheen. Well, that was a real quick whip through the whole process and the structure. So I think what we'll do is we'll open this straight up to colleagues on the call. We've also got Edward here as well, who I explained earlier on is the Policy and Portfolio Director at Guy's St Thomas's, and I think has worked closely with Shaheen in the development of this whole programme. We've got several questions in the chat that you may well have looked at already, Shaheen, or you can probably be having a peep at now. It might be while people are getting their heads together around what they might like to ask you, it might be worth going along with some of these first of all. So the first one I wanted to look at, where are we? There's a really good question there from Colin, I think, at Cardiff and Vale University Health Board. Lovely to have you with us, Colin. How has the public been involved while engaged in co-production of the virtual ward? I think this probably stems from the idea of start from the patient and work backwards. How have you consulted with the general public, the patient community, around what works, what doesn't work? Would you like to comment, either of you?
Yes, really important question. I didn't do it justice in the slides in terms of what our plans are. This has been a relatively fast-moving space, as some colleagues will know, that there was a specific tranche of funding identified and devolved locally, which we were keen to utilise. So the pace of that has meant that robust public and patient engagement has not been possible thus far, but within our maturity matrix work, that's absolutely a critical factor there in terms of how do we truly co-design services. So initially, what we've done is rapidly expand our current service offering and augment it with technology. And it's actually the technology that will help us coming back to the patient and public engagement, because we'll be using that as one of many strands to get feedback in a way that we've never done before for our services. So I think, and all the constituent stakeholders in the work, of course, whether that's the council, social care, voluntary care, etc., all have their own PPE input and strategy into that work. But I think what we're looking at is a defined piece of work, and that's built into the plans moving forward. What that precisely looks like is TBC. So if colleagues have got ideas on how that works, we're really keen to hear it. We don't want to reinvent wheels. We don't want it to be tokenistic. It needs to be genuine co-design and locally applicable as well, because there's national co-design we can simply take off the shelf and use. But if there's local stuff, then that's where we need to be focusing our energy.
Well, I'd written down the same thing. I'd written down, how are you auditing the patient experience? And I guess that's data that you're now keen to collect in an intelligent and effective manner. So that's, as you say, that's a work in progress. Andrew Robinson from Nottingham City says, are you able to provide details of the patient equipment and governance process for equipment approval for use? I guess this is connected with the procurement process, but hand on to yourself or Edward on this, please.
Yeah, so that's really helpful question. The procurement process was very robust from our perspective. We set out a formal process with the help of our colleagues in City, and had some very key requirements. One of those, for example, was that any partnership or provider we entered into had to have CQC accreditation. So there were a few kind of red lines that the successful company had to adhere to, because there are many companies in this space, as colleagues will know. And I think you all probably get emails every day from people offering technology and solutions to problems, sometimes problems you don't necessarily have. So I think it's really important that there's a robust procurement process, and the successful outcome of that was with the company that I mentioned. In terms of what the equipment looks like, each person accepted onto the caseload and has a personalised set of equipment which is couriered out to them, so they don't need to go anywhere or do anything to get it. And depending on what the need is, for example, if it's a respiratory issue or a cardiac issue or something else, they'll get what they need. So that might be, for example, oxygen sats probes, thermometers, can do a 6-lead ECG. It really depends on what we're anticipating needing to monitor, because what we absolutely don't want to do is overwhelm people with lots of equipment. People might have equipment from other sources as well. The equipment is also connected in a broad sense, so that the patient will get whatever they need in terms of a laptop, a phone, so that the data can be uploaded and it doesn't rely on the person themselves having a broadband connection or paying for the internet, which again is an important consideration in our local population.
I'm so glad you mentioned that. That's just I know that's on a few other people's minds, and we've done events on virtual wards in the past, and that's regularly been discussed. Bharti Malhotra, hello Bharti from Imperial College, has asked, how's this funded? Is this additional funding for the trusts or funded separately by the Integrated Care Board?
Thank you. So it's a bit of both. So what we've been doing, like I say, for the last 9 to 10 years is built in. That's our business as usual. So we essentially, we're funded to do that as business as usual. And then much more recently, in the last 12 months or so, there was a national allocation of funding from NHSE for virtual ward expansion work, which obviously everyone was invited to utilise. That money was drawn down at the ICB level for us at SEL level, and then providers across SEL were invited to submit proposals on how that funding could be best utilised for, from the taxpayer's perspective, for the benefit of the local population. So for Lambeth and Southwark, Guy's and St Thomas's led a joint bid on behalf of all of our local partners, and so we have been able to draw down on additional funding. And it's that funding that we've been using in the last few months to expand our clinical staffing to a small extent, and also enter into our pilot scoping work with DOCLA as well.
I can see that there are questions coming absolutely thick and fast through the chat, and I knew this was going to happen. It's such an interesting topic, and if I may say, Shaheen, yourself and colleagues have clearly given this a huge amount of thought, and you've got the legacy experience as well. I don't think we're going to have time to ask all of these questions, so what we might do is ask you to, maybe through Jade Maloney, to collect these questions, and then maybe we could issue this as a follow-up, sort of written answers basically, to some of the questions subsequent. That would be very helpful if you wouldn't mind yourself and Edward and colleagues giving that some thought. There are a couple of things that maybe we've got time for right now. I wonder if you could answer the question about, do you have a step down model? So, you know,
Yeah.
if this is not suitable for somebody or they move beyond it, how do you step down?
Yeah, so if you think about the totality of the people we care for under our virtual ward umbrella, roughly, and this is obviously different in different elements, roughly 50% of the referrals come for step up. So that's for people already in their own home. And in this context, their own home might be a nursing home, residential home, a hostel, a prison, you know, various locations. And the other 50% are what we call step down. So people who are currently in inpatient hospital beds. For us locally, that's largely Guy's, St Thomas's, King's College Hospital, Denmark Hill and St George's. So roughly it's 50-50 people coming out of hospital who we can extract from hospital quicker, or people who are already in home who otherwise might require an admission into hospital.
Perfect. Okay. Can you just, I'm going to kind of try to synthesize a few questions here, but there is a really important one here about efficiency, I think, because this is not, as far as I understand it from previous virtual wards analyses we've done, this is not necessarily cheaper or quicker or easier. You know, this takes effort and it takes planning and it takes workforce. And you have to devote the same kind of attention to this as one would do really with an inpatient experience. And I just wonder if you'd be prepared to comment on that at all, Shaheen. You know, this is not a quick fix, is it?
Absolutely not a quick fix. And I think the comments and questions from colleagues around the governance, the sustainability of funding, all very pertinent. I think there, in terms of cost effectiveness, actually is significantly cheaper if you're treating the right patients with the right staff. It results in significant savings for the NHS. So that's evidence-based. We don't need to demonstrate that locally. Providing a virtual ward is not a pilot. It's an evidence-based intervention that is applied to a greater or lesser extent in different parts of the country. In terms of I guess the other aspect of this is that this is not a choice for us. This is not an optional luxury add-on. We're sitting on and dealing with time bombs of all sorts. So I've referenced the aging multi-morbid population, the financial constraints we're in, the shift of care from the acute to the community setting. But more important than all of that, it's what our patients want. So when you talk to people, where would you like to have your care? You know, for the right person, you know, that's not always in an emergency department. And so actually it ticks off all of those boxes. But the flip side of that is all of the challenges around resourcing it, both from a staff and logistical perspective, and the sustainability. Yeah. And I think for the system as a whole, there are some elephants in the room that we need to track down and talk about, which is really starting to have that difficult conversation around shifting resource from existing parts of the system towards this direction, because we're not going to have loads of new money coming in, irrespective of what happens politically. I think Ed's going to add to that.
Yeah, go ahead. And I'm interested as well is how staff responded who were sort of being reallocated, or you know, I'm just interested in how you managed that. Perhaps you could comment, Ed.
Yeah, well, I was just going to add to what Shaheen said, that I think, you know, virtual wards are an excellent example of the frontier of kind of remote care and the transition of care out of hospitals. But with that comes a real change in practice and behaviours and culture for clinical staff working in inpatient settings. So one of the things that Shaheen mentioned in the slides is that if virtual wards become a safety net where patients on the margin of being discharged are effectively kept within the trust, albeit in a remote setting for an extra few days, they won't meet the kind of freeing up capacity goal that they've been established for. So, you know, part of this is working with clinical teams to make sure that they feel confident to move patients out earlier than they otherwise would have done into a community setting. And that's not just for virtual wards. We'll need to see that change in behaviour and culture and lots of other aspects of remote care as well.
And just in terms of the staff, I think and colleagues will add on the call, but working in these services requires a distinct skill set. There's obviously huge transferability, but this is not a service that works well if you suddenly, reallocate people from a ward environment into the community. There are some challenges with the terminology here that it's important to emphasize, that because whilst we're using the term virtual ward, and that's absolutely the umbrella term, the direction of travel, actually, if you think about what I've talked about, there's nothing virtual about this, and there's nothing ward about this. This is not a ward in this typical sense, and these are real people being cared for by real people. So virtual ward itself is a term that lends itself to some confusion. It's important to acknowledge that, I think.
Thank you, Shaheen. Well, look, as I say, we could be here until sort of 4 o'clock tomorrow afternoon to answer all of the questions. There's an interesting one from Susan, perhaps Susan Singleton. Could you just talk, how do you manage investigations such as bloods, etc.?
Yeah, but really good question, and particularly in most settings, these are relatively urgent investigations. So if we think back to wave 1 of COVID, we were managing severely ill people with COVID at home, and you needed access to the results, of course, immediately. So we essentially regard these people as in the same way as inpatients. So if someone needs an investigation, blood test, a swab, they're registered on our trust system, our PIMS. So in the same way that if they were an inpatient, they get all those tests. There's obviously some logistical challenges with couriering things over, getting results back, but all the results are processed. And this is the benefit for us of being an integrated trust, that they're all processed in the same place. All the results are available on the same system. And this extends, by the way, to radiology. So if someone needs a same-day CT scan, which of course is not that common, but if they do, they'll be prioritised just as quickly as if they were an inpatient on the North Wing at St Thomas's. So there are established processes for all of those things, because, yeah, really good point, Susan. Without those things, we don't have the confidence to take on complex, complicated patients. And then you end up with virtual wards just seeing really simple cases that don't necessarily need to be seen. So, yeah, really good point.
I do think it's worth emphasising the collaborative, integrated nature of what you have and what you've embraced, really, where it's not just St Thomas's or Guy's doing this. This is an integrated approach across primary and so on as well, and community, where and social care for that matter, where you've got genuine working together, as far as I can tell, to make this work properly. So that's lovely. Quick comment, if you wouldn't mind, Shaheen or Ed, about your link with clinical engineering colleagues around, how do we make certain that the equipment is fit for purpose and is working properly and is calibrated and all that kind of stuff.
Yeah, so for most of our if you think about our standard or BAU equipment, medical equipment library type processes in place. So, if you look at procurement of devices, maintenance, that's all covered by the appropriate governance. And then when it comes to the partnership with DOCLA, much more recently, DOCLA have an additional layer. Of course, they have their own quality assurance processes. There's a question in the chat around the overall clinical responsibility, which is a vital one. Essentially, for the way that we've constructed this is that we have the overall clinical responsibility. We're utilising technology and DOCLA to help us in that space, but the governance is really clear that these are patients under the care of Guy's and St Thomas's, whether they're being seen by a nurse or sending us a piece of telemetry. They're under our care and we are responsible. So we have high levels of, we have a high bar for that. Yeah.
Well, look, I daren't go on any longer on this. Otherwise, the lovely Claire Harris will be just tearing her hair out, basically. But look, that's box office, folks. Doesn't get any more precise and current and relevant than that. Shaheen, we're immensely grateful to you and your colleague Edward and all of your team. Actually, please send our thanks and best wishes to all of them. It sounds like you're doing great work. And if you wouldn't mind, would you come back in maybe, I don't know, 6 months, 9 months time and just tell us how it's further evolved? I think that would be very interesting. People are rightly very interested in how this is being made to work. And depending on where you are around the United Kingdom, you've got your own challenges. around geography and digital links and so on. So it'd be really interesting to see how this evolves now. But thank you both. Let's just give them a big clap, everybody. A whoop whoop. If you want to do that, that's fine. And if you'd like to contact Shaheen and Edward subsequently, I'm sure they'd be generous enough to allow us to put you in touch with them. If you contact Jade Maloney, jmaloney@ihm.org.uk, we will facilitate that for you. And Linda, yes, we will be sharing the recording of this meeting. So, you know, don't worry. We've got you. OK. All right. Thank you very much, Shaheen and Ed.